Hi, this is Danica Nichols recording for Nursing 620, Primary Care of Women and Children. This is my Women's Literature Review. So a little bit of overview. Throughout this presentation, I'll be discussing multiple aspects of premenstrual syndrome, of which main points will include the epidemiology and demographics, causes and risk factors, pathophysiology, the patient's common presentation, history and physical examination, differential diagnosis, diagnostics, treatment management, and additional patient education. So my objectives: by the end of this presentation, the student will be able to state the epidemiology and the pathophysiology of premenstrual syndrome. Students will also be able to establish the possible differential diagnoses as it relates to PMS. Students will be able to recognize important factors within the H&P. There will be an understanding of the potential diagnostic tests to rule out other causes of the patient's presenting symptoms. There will be an understanding of various treatment options based on the patient's severity of symptoms, and there will be an understanding of patient education as it relates to premenstrual syndrome. So as an introduction, premenstrual syndrome is defined as a cyclic reoccurrence during the luteal phase of the menstrual cycle of somatic, affective, and behavioral disturbances that are of sufficient severity to affect interpersonal relationships adversely or interfere with normal activities. So premenstrual syndrome, commonly called PMS, occurs during the luteal phase of menstruation and is typically relieved by day 4 of menstruation. The ICD-10 code is N94.3, also known as premenstrual tension syndrome. So for PMS, there is an unknown etiology. However, it affects 20 to 40% of women, with up to 20% experiencing moderate symptoms and up to 40% having mild to moderate symptoms. 3 out of 4 women will notice a physical or emotional changes occurring during the luteal phase of menstruation. And age will typically vary in regards to symptoms. It can range from menarche to menopause, with most of the women seeking care between their 30s and 40s. There's very little variability among the menstrual cycle in women, occurring from ages to 20 to 40. So usually a typical menstrual cycle is pretty linear across this age group. And the most common time for cycle variability occurs between the first 5 to 7 years after menarche and during the last 10 years before cessation of menstruation. So causes: this is typically caused by a complex hormonal interaction, so an alteration in the level of estrogen and progesterone. Also can be caused by a neuroendocrine disorder and other psychological or psychosocial factors. So women who have premenstrual syndrome will experience a very wide variety of cyclic and or recurrent physical, emotional, behavioral, and cognitive symptoms that will typically resolve after the start of menses. Although the cause is not necessarily known, a typical history or a typical theory is by a hormonal imbalance and fluctuations in estrogen and progesterone. So some of the contributory factors, there is a possible genetic contribution. And women with pre-existing emotional stress, such as generalized anxiety disorder, depression, or social issues. Smoking or other negative lifestyle factors may exacerbate the symptoms of PMS. Other menstrual disorders such as abnormal uterine bleeding, menorrhagia, endometriosis, or dysmenorrhea. Other medical conditions that can be associated with PMS include hypothyroidism, anemia, chronic fatigue syndrome, and chronic pain disorders. So as I stated in the previous slide, the ages that this is commonly a complaint of includes women who are in their late 20s to early 40s. So for the pathophysiology, because the etiology is relatively unknown, mainly just has to do with the female menstrual cycle, and the average adult menstrual cycle lasts from 28 to 35 days and will typically peak when women are ages 25 to 30, and then after that will gradually decline to shorter cycles. So the physiology of the normal menstrual cycle will include, I'll kind of talk about a normal menstrual cycle of 28 days. So the first phase is the menstrual phase, which occurs during days 1 to 5, in which the first day is the first day of bleeding or spotting. And at this point, estrogen and progesterone levels are at their lowest levels. Next comes the follicular phase, which includes days 6 to 12. And during this, it typically occurs after menstruation has ended. And during this time, estrogen and progesterone is made by the ovaries and causes changes to the lining of the uterus. And also during this time, the ovarian follicles and eggs start to mature and get ready for ovulation. So during the ovulatory phase, this typically occurs between days 13 to 15. And the egg is usually released around day 14 to prepare for possible fertilization. So during this time, there's a surge in the luteinizing hormone, in which the largest follicle will burst, and at that point the egg is released into the fallopian tube and will make its way down through the uterus. So the final phase is the luteal phase or secretory phase, which lasts from days 16 to 28. And in the case that the egg is not fertilized by a sperm, the corpus luteum will begin to degenerate, and this will cause levels of estrogen and progesterone to decrease. So once these hormones have decreased, the menstrual cycle will start over again. And during the luteal phase is also when most of the PMS symptoms will occur, possibly due to that estrogen and progesterone, those low levels. So in this next slide, you can see the various changes that occur during a typical 28-day menstrual cycle. They just say the typical 28 days, but that's not necessarily the case for all women, and it can range from 21 to 40 days, just depending. So in this picture, at the bottom, it has the days of menstruation from day 1 to day 28, and at the top, you can see how FSH and LH are running pretty steady, and then around days 12 to 16 or so, it has a surge, and then they level out again. Same thing with the estrogen and progesterone. There is a slight surge during days 10 to 13, comes down again, and then levels go up again from days 15 on to days 24. Then you can see on the very bottom portion kind of how the lining of the uterus shows. So starting with menstruation, and then as you can see from days 6 to 14, there is proliferation phase in which the uterine wall is building up, and then the secretory phase where it's all the way built up, and then menstruation occurs. So slide 9 here kind of shows the same thing as the previous slide, just in a different picture. So some of the common presenting symptoms that a provider may encounter, these are typically mood-related or affective symptoms, including depression, sadness, anxiety, anger, irritability, or frequent and severe mood swings. Typically, the complaint with these is that it occurs in a cyclic fashion rather than constant or occurring all the time. There's also some mental process symptoms or cognitive symptoms, such as decreased concentration or indecision. Patient may also complain of pain, such as a headache, backache, breast tenderness, or joint and muscle pain. Other nervous system symptoms include insomnia, hypersomnia, anorexia, food cravings, fatigue, lethargy, agitation, change in sex drive, clumsiness, dizziness or vertigo, or prickling or tingling sensation of the extremities. GI symptoms, the patient may experience nausea, diarrhea, palpitations, or sweating. Fluid and electrolyte imbalances can cause the patient to experience bloating, weight gain, and reduced urination. Skin symptoms, patient may complain of increased acne, oily skin, greasy or dry hair as well. So during your history and physical examination, the symptoms should be described by the patient and will typically follow kind of a cyclic order to them, and usually occurs before menstruation and is relieved by the end of the menstrual flow. So most of your diagnosis is going to come from your history, and this occurs through medical and family history, including gynecologic, obstetric, and menstrual history as well. So patients should be encouraged to keep a diary of their menstrual cycles, including not only their physical but their psychological changes that they experience over a few months in order to make an accurate cyclic diagnosis. The provider should also establish what, if anything, has helped or exacerbated the patient's symptoms. So essentially having the provider just following those old CARTS topics. Also during the H&P, the provider should screen for depression, evaluate for any sleep problems, changes in weight, impaired concentration, reduced sex drive, and how the patient perceives their mood and any suicidal thoughts or tendencies that they may have. So the general physical examination should have an emphasis more so on BMI, a thyroid exam, breast examination, only if the patient is complaining of any breast symptoms, lumps or bumps or dimpling. Also, if there's any symptoms that can be suggestive of an underlying malignancy, a bimanual pelvic examination should be done. Also, if the patient has had any chronic pelvic pain, weight loss, abdominal pain, abdominal swelling, or any fertility issues. So in formulating your differential diagnosis, depression would be the main differential for PMS, with the main features being having a low mood, anxiousness, appetite changes, sleep disturbances, reduced libido, and anhedonia, which are all very common findings in PMS. Another possible differential is premenstrual dysphoric disorder, which is a more severe form of PMS in which the symptoms of anger, irritability, and internal tension are prominent. Other differentials would include hypothyroidism, anemia, endometriosis, and physiologic ovarian cysts. These may also replicate the symptoms of PMS. Pregnancy should also be ruled out, as the early pregnancy symptoms may mimic those of PMS, such as breast pain, bloating, swelling, constipation, tiredness, mood swings, and headaches.